Good morning, everyone, and welcome. I'll ask you to please take your seat, and we're about to get started. So good morning, and welcome to Crohn's and Colitis Canada's BC Symposium. Thank you for being here. We recognize and respect that New Westminster is on the unceded and unsurrendered land of the Halko-Melman speaking people. We acknowledge that colonialism has made invisible their histories and connections to the land. My name is Matthew Sebastiani. I'm the president of the Vancouver chapter of Crohn's and Colitis Canada, an IBD advocate, and like many of you, an IBD warrior. And I'm pleased to be your MC today. We look forward to a day of learning, sharing, and hearing from some of Canada's top IBD researchers and healthcare providers. It is a special opportunity to connect directly with leaders in the field here in the Vancouver area and strengthen knowledge of Crohn's disease and ulcerative colitis. You'll notice as you entered, each chair had a roll of toilet paper wrapped with our Go Here tag. The Go Here program is designed by Crohn's and Colitis Canada. It's an app that is available free to download that identifies public washrooms, locations either near you or you can enter in your route and it will show you the washrooms along the way. You can use a washroom with no questions asked. Across the country, we're working hard to identify new locations. If you know of any businesses that would like to participate in the program, we ask you to refer them to the Go Here website on crohnsandcolitis.ca to register. I'm proud to announce that the Anvil Center, where we are today, is a location in the app. Thank you to the City of New Westminster for their support. The Vancouver chapter has been working hard this year to secure many cities' support, and New Westminster has joined other cities within the Vancouver chapter in supporting the program. And we want to thank all of those who participate in our Go Here program. In your welcome package, you would have also received a booth passport. We encourage you during the day to visit booths and get stamps at each location. There are 7 booths. One booth wasn't able to attend today, so I think that shows 8, but there's 7. And completed passports can be dropped off at the Crohn's and Colitis Canada booth, which is the last booth around the corner, and you can be eligible for a prize. 2 lucky people will win a Crohn's and Colitis Canada survival kit. Check out that pricing at that booth. The 8 booths with us today include Dr. Laura Sly, related to research, Kathleen Duddy, pain management, Simon Lisango, mental health, Lauren Wolf, ostomy care, Gina Almasan, diet and nutrition, and Dr. Bruce Valance, related to research. Today is going to be an exciting day. We're going to start the morning with a presentation from Dr. Laura Sly. Followed by that, we're going to have breakout rooms just to the right of my right of the main ballroom here. And then we'll have lunch. We can come back here for that lunch, and then we'll have another round of breakout rooms in the afternoon, followed by a panel discussion, which will be back here in the main ballroom, and you'll have an opportunity to ask questions. Throughout the day and the sessions, we encourage you to think about questions that you would like to ask later for today's panel. Today's event would not have been possible without the support of 2 amazing individuals that have sponsored today's event. I'd like to ask George Pick and Santi Pelez to please stand so we can recognize their sponsorship. A huge thank you for your generosity today. I'd also like to acknowledge our speakers for the time and dedication to share their expertise with us. So when I call your name, if you can please stand to be recognized. Gina Almasan. Gina's the registered dietitian at the IBD Center of British Columbia. We also have Kathleen Duddy, pediatric nurse practitioner in acute pain service at BC Children's Hospital. Dr. Nancy Fu, clinical assistant professor of gastroenterology at Richmond General Hospital. not here at the moment. That's okay. He'll be with us shortly. Dr. Simon Lisango, Assistant Professor of Teaching School and Applied Child Psychology at the University of British Columbia. And he's right here. Dr. Laura Sly, Professor, Division of Gastroenterology, Department of Pediatrics in the Faculty of Medicine at the University of British Columbia. And Lauren Wolf, Certified Wound Ostomy and Continence Nurse at McDonald's Prescriptions and Vancouver General Hospital. Thank you. And a big round of applause for all of our speakers today. I'd like to also take a moment to recognize our volunteers and staff for helping to make this event possible. Let's also give them a round of applause. And on the note of volunteers, yesterday volunteers from across the country with Crohn's and Colitis Canada gathered in our National Guts Conference. And I'm pleased to announce that one of our amazing volunteers in the Vancouver area in Fraser Valley West, Krista Olson, was awarded Crohn's and Colitis Canada's BC Unsung Hero Award. Congratulations, Krista. Before we jump into the first presentation, I'd like to call on Sarah Hillefer, Senior Manager of Corporate Events at Crohn's and Colitis Canada, to speak about our patient care programs. Sarah.
Thanks so much, Matthew. Hi, everyone. Nice to see a room full of so many faces here to learn a little bit more about CCC, IBD, and I'm here today to speak to you a little bit about our patient programs and what we have available and some of them you might know about, some of them Matthew spoke about a little bit already, but just to give you an overview of everything we do here at CCC. So on a whole, there are several programs that we have at Crohn's and Colitis Canada meant for people of all ages at all stages of their journey of living with IBD. I'll be focusing on these ones here today, but knowing that as part of our PACE program, which I'll speak about at the end, we are always looking at adding new programs and new services that have been tested out through our clinical trial program. So to begin with, we offer a variety of patient programs at Crohn's and Colitis Canada, specifically in the peer support section. When you join our peer support program, there's a very easy link that you can follow online, and you can join either as a mentor or a mentee. If you join as someone who's new to living with IBD or just has some questions looking to be paired up with someone else, you'll go through a screening process where we'll look at what it is you're looking to learn at and pair you with someone else who has gone through the same thing and might have some advice for you. The program is shifting to an online format over the next little while, and there's a lot of educational resources that are paired with it as well. So one of the things that I love about it is that regardless of where you are in your journey, there's always someone there to help you and someone there to guide you through any stage of thing. And it could be, navigating work or navigating mental health, navigating family, navigating washrooms, everything that comes with living with IBD. There's always someone there to help you along the way. The next thing, I'm not going to spend too much time today, but the next thing I wanted to speak about was our Go Here washroom program. Matthew already did a wonderful job shouting it out, so I'm just going to take this opportunity here to shout out Matthew, who has done such a wonderful job on having so many of the cities in the Lower Mainland sign up to have their facilities opened up to folks living with IBD. As Matthew mentioned, the app is very easy to download. You don't have to do anything to sign up. You can just download. There's a washroom access card in it. I think it's quite wonderful. I know for me, it's always very stressful when I'm out and about trying to find the closest washroom and going into somewhere going, oh my gosh, are they going to let me in? I don't even have time to have a conversation with the person on whether or not they're going to let me in. And I think it's just a wonderful way to kind of ease that stress and ease that anxiety when you're out and about to help you live your lives in a much easier fashion. The next program here, this is one of the really exciting ones that we are in the process of. We've launched it already, but we're in the process as well of creating a pilot program here as well that's going to further expand on this program, and that's our My Gut app. So our My Gut app is available right now. You can go on your phones right now and download it here. And there's a few things that you can look at today. So the first one is daily activity tracking. This is just a way that you can log how your symptoms are, how your mood is, how you're feeling, and just get a standard overview of how your symptoms are and how they're progressing. The next portion here is in educational resources. So there's a lot of information that's constantly being added to the app, whether that's information on diet, information on treatment, information on just general care, things you might want to know as you're navigating your IBD journey. The third part, and this is a portion that we're looking at expanding even more, but right now you can go on and it's got some pretty standard reports that you can print off for your healthcare practitioner. So I don't know about you, but it's often really difficult to remember like, oh, what was I feeling a month ago? What was I feeling 2 months ago? Where are things at? How's that all going? And so this helps you have a really nice, easy way to log all of that and then hand it over to your practitioner and have them give an overview and an understanding of, or have them get an overview and an understanding of what's been going on for you. Where this part is really interesting and where it is getting further expanded is that right now in one of our clinical trials, we're taking My Gut and we're pairing it with a back end portion of the app that your physician actually has access to. So your physician can go ahead and set all these different parameters here, all of these different, I call them like triggers or like if then, right? So if this happens, then this. So when they're working with you, they set out this whole program. And as you're logging your symptoms, there's a nurse practitioner who's on site at CCC who has the ability to look in, see how things are trending, and actually get a flag when something is a little bit off that might trigger one of these if-then. The coolest thing about this, I think, is that while you're waiting then for an appointment to get in with your GI, maybe a flare's come up unexpectedly, where you're waiting for an appointment to get your GI, the nurse practitioner can already start ordering tests, ordering blood work, maybe prescribing emergency medication based on what the physician has outlined in your protocol. So it's a really neat way for you to kind of have a holistic way of managing your care. And as this program continues to grow and continues to evolve, we'll be expanding it further across the country and also adding different components that we're looking at, like mental health. So for example, low mood reported on a certain amount of days. Eventually we'll have a social worker on staff who will work with that and maybe direct you to the right direction of getting some mental health support as well. So really like looking at someone as a whole in their journey. There's also questionnaires here as well. They look at the quality of life, how things are going for you. There's this really well done, well studied questionnaire that we use called the SIBDQ. What it looks at is the quality of life of people living with IBD. And so as you are going through and working within the My Gut app, you'll have different questionnaires that will help you monitor your progress over time. And it'll also help tailor some of the content that you're receiving. One of the other programs that we have to offer is the Gutsy Learning Series. So the Gutsy Learning Series is a webinar that takes place every few months, and it's on a variety of different topics, often presented by experts in the field. So one of the most recent ones that we did looked at the Mediterranean diet. And so we actually brought in a dietitian and a nutritionist to come in and speak to there's people, oftentimes they're online as well as in person. So there's a host of different ways that they're delivered. But if you miss them, you can always go online and the recorded versions are posted on our website. So if there's any topic up here that might seem of interest to you that you'd like to go check out, if you go onto our website and just search Gutsy Learning Series, it will come up there as well. And you've got access to all of the past talks that have happened. The frequency is about once every month, and they're often highlighted in our regular emails that go out with just more information on what's coming up and what you can look forward to. So these are some of the ones that we have going on. I know one of the ones that I'm working on right now in the next year is actually looking at navigating pharmaceuticals. So navigating getting MSP to cover certain things, navigating how do you work with your third care party programs, how do you kind of maneuver through the whole system when it comes to prescription medication. So that should be in like the next year. We're working on building it out right now with a few pharmacy partners. This one is one of my favorites, Camp Got to Go. So for folks between the ages of 9 to 17 who have been recently diagnosed or have been living with IBD for a while, we have the opportunity to send all of these kids to camp. You apply, you can go to camp. Crohn's and Colitis Canada, with the help of our sponsors, pays for the camp fees for everyone, so it's free and affordable. And it's a great opportunity for children between the ages of 9 and 17 to meet other kids living with IBD. It's a very difficult thing when you're diagnosed at such a young age. Symptoms can often be embarrassing for that age group, and it's hard to navigate with friends who might not understand, especially at 9 years old. So this is a great opportunity where children living with IBD might be meeting another kid living with IBD for the first time. And there's 3 camp locations across the country. There's one in Alberta, which is for everyone in Western Canada. So BC as well, you're welcome to apply there. Ontario for Central Canada, and then Nova Scotia for Eastern Canada. And I wanted to take a few minutes just to show you a video. I'm hoping that it works, but I'll show you a video of what it's like for the children who are attending our camps. Let's see. Oh, no. Okay. There we go. Are you able to click play for me, please? It's not working. Okay. Well, we will share the video afterwards. It's a really nice snapshot into what it's like for children living with IBD and getting to hear them speak about their experiences. And we'll see if we can line it up to play it at some point today as well. Lastly, the last thing I want to speak to you about today is our PACE program. And so PACE encompasses all of the programs that we are currently in the process of trialing. So there are a lot of different and interesting programs encompassed within PACE, and a few of them I will touch on, and a few of them we're actually touching on today, which is really exciting. So the first one is improving rural care. One of the things that is very difficult is when you're living in more rural parts of Canada, that it is really difficult to access GI care. An interesting stat that horrifies me is that right now in the entire province of Saskatchewan, there is not a single pediatric GI in the entire province. So how do these children access care? Well, it's often their parents packing them up into the car, driving for 8 to 12 hours to get to an appointment, going to the appointment and coming back. How reasonable is that? Like, it's completely unreasonable. They lost 3 pediatric GIs within the span of a year. And the province only had 3 pediatric GIs before that, so also a problem. So one of the things that we're looking at is how do we improve that rural care, and how do we get support to people living in rural communities so they're not having to do that travel, and that they're getting care as they need it. The next one is one of the programs that I am very passionate about, and I could speak to you for probably hours on it, is the Youth to Adult Transition Program. And one of the things that I think is so interesting is that when you're switching from peds care to adult care, it often changes very drastically. So you're a young person, age of 17, 18, you're navigating all of those normal big life changes that happen around that time, where you're, maybe going off to university, maybe you're starting your first full-time job, you're maybe moving out of the house. There's a lot of big decisions that happen during that time period. And you're also then having to navigate switching your entire care team from your peds care team to an adult care team. And that alone in and of itself is a stressful full-time job, in addition to all of the other things that you need to be doing during that time period. So what our Youth to Adult Transition Program helps with is assisting in that navigating, understanding what you need to know as you're going through that process. I believe there's a breakout group that we're talking about that today. And it's just a really nice way to support folks as they're moving through that transition. Our digital health program, I've spoke about that. That includes My Gut as well as Go Here, as well as our peer-to-peer support program that will be moving online and looking at how all of those integrate together. standardizing treatment. So right now, across different provinces, across different facilities, there's different pathways that are navigated. And what we're looking at doing is having set clinical care pathways so that it's a lot easier for someone to navigate through their IBD journey. And then the last one is looking at mental health, diet, and nutrition, and really looking at that mind-gut balance. So a lot of different programs here that we are looking at that are piloting, that are being looked at, that will then eventually roll out nationally, which is quite cool over the next few years. So just giving you a look at what's to come as well. So that is our overview of our patient programs. I hope that this was helpful for you. I wanted to call out, we've got these toilet paper rolls on the table for Go here. If you scan that QR code, it'll help you open and download the app. And then you can bring yourself home a nice roll of toilet paper because everyone needs one of those. All right, thank you so much, everyone. If you have any further questions, I'll be around all day, so feel free to pull me aside and we can chat a little more.
Great. Thank you so much, Sarah. It was really good to just get a better idea of some of the programs that Crohn's and Colitis Canada offers for patients across the country. So thank you for sharing. I'd like to now introduce our first speaker today, Dr. Laura Sly, a professor in the Department of Pediatrics, Division of Gastroenterology at BC Children's Hospital and the University of British Columbia. Her research program focuses on understanding the inflammation that causes inflammatory bowel disease, Crohn's disease, and ulcerative colitis, so that she can identify new ways to treat these devastating diseases. In work funded by Crohn's and Colitis Canada, she is working with a company that has developed new and improved inhibitors that block specific cell-to-cell communication to prevent cells from ramping up damaging inflammatory responses. By determining how these inhibitors work, we may be able to develop an entirely new way to block inflammation and treat people with inflammatory bowel disease. It sounds like amazing and innovative work, and I'm looking forward to this presentation. I'm pleased to invite Dr. Laura Sly to the podium.
Good morning, everyone. It is a real pleasure to be here and a real pleasure to be back in person at the Crohn's and Colitis events. We've had many small events and I haven't had the opportunity to speak to a large crowd and see everyone gathered together for many years now. So thrilled that we've been able to initiate these again. So this is a disclaimer from Crohn's and Colitis Canada that they've asked us to include in our presentations. The material that I'm going to present to you today, the updates that I'm going to present to you today are about the GEM project, which is funded by Crohn's and Colitis Canada. And these are not to replace medical advice. And absolutely for your care, go to your care provider. So I'm going to talk about two things. I'm going to give an update on the GEM project, but I actually wanted to begin with a shout out to Crohn's and Colitis Canada. The GI community and the research community in Canada is extraordinary, and we punch well above our weight internationally for the impacts that we've made and the contributions to care that have been made. And I actually attribute this to the involvement of Crohn's and Colitis Canada, not only in advocacy, which is phenomenal and wonderful programs that they run, but actually in the funding that they do for research. It has brought the community together in new ways, and I think that's why GI research is so successful in Canada above other things, just because Crohn's and Colitis Canada has been an extra funding source, an extra community that brings us together annually for the Meeting of the Minds, the annual meeting, and provides research dollars, support, and interactions. I'm going to talk to you about the project that I'm working on, and actually it's with Dr. Harry Brummer, a chemist from the University of British Columbia, who actually, as it turns out, studies IBD with me now. And we actually met at a Crohn's and Colitis Canada event. It was one of the fireside chats that we did, and we actually heard what each other did in their research for the first time. Even though we're both professors at UBC, we didn't run into each other there. We met at a Crohn's and Colitis event, and we started a collaboration right before COVID. We've been going for 5+ years now, and that's the project that I'm going to present to you today, entirely enabled by Crohn's and Colitis Canada. So the first thing that I'm going to talk to you about is the GEM project. And this has been a big research investment by Crohn's and Colitis Canada that's been going on for probably 15+ years now, and really got through the data discovery and the basic phases and is really starting to have huge impacts now. So a gem of a project. And this project was led by Ken Croiteru. He is a clinician scientist, fantastic scientist. He's an immunologist by training. And this was his brainchild. And he collaborates with people all across Canada with other clinician scientists who provide samples for this project. And GEM stands for genetic, environmental, and microbiome. So those are the three things that they're looking at in this project. So the initial project plan, this has evolved over time, but started more than 15 years ago. And the phase 1 recruitment, it started with just a brilliant idea. And the idea was, we know that people with Crohn's disease, their first-degree relatives have a higher chance of developing Crohn's disease. So they did the math and they did the calculations, and they figured if we look at 5,000 people, we will find 75 people in the next 5 years that are going to convert from being no Crohn's disease to having Crohn's disease. And that what they did was they collected samples from those individuals before they developed Crohn's disease and after they developed Crohn's disease, to look for biomarkers, to look for clues as to the origins of disease. What is it that contributes to some people getting disease and others not developing disease? So they've actually recruited, they finished the recruitment of more than 5,000 patients, and they've had a number of people who were first-degree relatives of somebody with Crohn's disease that have gone on to develop Crohn's disease. So they have that pool of people with disease, and they have a bunch of control individuals that didn't develop disease and are starting to look for the differences between the samples that they got from those people. They've actually started a next iteration of that project, and there is new recruitment going on and ongoing recruitment. And these are, again, now individuals who are healthy, but they have multiplex families. That means that you have 2 or more people in your immediate family that have Crohn's disease. So for any individuals that are 6 to 35 years of age that do not have Crohn's disease, and 2 first-degree relatives, so that a first-degree relative is either a mother or father, a sibling at the same generation as you, or a child with Crohn's disease, we're asking people to enroll. And what they're going to do, which is unique in this study, they're going to collect blood samples, they're going to collect stool samples, and they're going to collect urine samples, and they're going to do that twice per year. So more frequent sampling from these individuals. Because these people will have 2 people in their direct circle, in their immediate family, with Crohn's disease, we expect the conversion rate to be higher, and we're going to have a better longitudinal look at what's happening. And the goal then will be to identify markers that play a role in disease and do some discovery of some of the earliest events that are occurring or earliest changes that are occurring prior to developing Crohn's disease. I'm going to highlight, like, the papers that are coming out of this group are phenomenal. It really is awe-striking. And these are just from the past 2 years that I've selected 3 of the biggest papers that they had. This one appeared in Gastroenterology, which is the premier journal for gastroenterology-specific research, so the biggest wow factor for scientists. And what they found, they looked at the gut microbiome. So they used the stool samples that they collected from people before they developed Crohn's disease to find out which bacteria that live in the gut that were most likely to be associated with the development of disease. And they identified 5 very important bugs. It's really interesting because we've always thought that the microbiome was really important in inflammatory bowel disease, but there was no direct proof. It's a really hard question to ask without this giant cohort of people. And this has provided now the first real evidence that there are specific microbes associated with the risk of developing disease. So the second most prominent journal in our field is called Gut. And it is an equally impressive journal to be in. And this was a paper that the GEM project published in Gut in August of this year. And what they did, for this one, they used the serum samples that they collected from people. So these were the blood samples. They isolated serum from them, and they looked at all of the proteins that were in that serum. And they were looking for what the changes were in people with Crohn's disease, or people who went on to develop Crohn's disease. This was actually really remarkable to me, because what they found was that there was a difference in serum you can detect. Because of the limits of detection, there's about 500 proteins that you can detect. They found there were changes in 25 of those proteins. That's really remarkable. That means that what is circulating in your blood, about 20% of that is different in people who are going to go on to develop Crohn's disease. So some of the first and earliest biomarkers of disease can be found in blood samples. And this could be really helpful for people as they're potentially developing disease. It could be something to look for, and it may allow early intervention to prevent or delay onset of disease. One protein, CXCL9, those are chemokines. They're the proteins that tell cells to move into an area. So they recruit cells. So they make your white blood cells move to a specific location. And I must say, the chemokine biologists are not very creative namers. So they all have names like CCL or CCX or CXC. So that protein actually was the best predictor, and it was associated with all of the other positive predictors of disease development. And it's important in recruiting immune cells to sites of inflammation. And I think that this highlights some of the earliest features that we can look for development of disease, because this is before someone has even become sick or been aware that they're sick, potentially permitting really early intervention in disease and hopefully a change in the course of disease for that individual. Because it was a chemokine that was important in this, we know that both the immune response and barrier function, again, which we've always suspected are important in the development of Crohn's disease. This was some of the first real direct evidence that these are initiating events in the development of Crohn's disease. They actually did, Mediterranean diet is all the rage. It is, there's a lot of talk about Mediterranean diet and how it might impact inflammatory bowel disease. And lots of people are doing studies to look at that. So a Mediterranean diet, high fruits and vegetables, healthy lean proteins, seeds, nuts, fiber sources being very natural fiber sources. And the GEM study wasn't a diet study. It wasn't intentionally proposed that way, but they took questionnaires from people, and they used the questionnaires from those people to publish this last year in Gastroenterology to ask if we could have any information about the Mediterranean diet and how it might affect the well-being of people with inflammatory bowel disease. So they didn't actually put people on a Mediterranean diet. That would be the ideal experiment. Have 1,000 people and 1,000 controls. These ones get Mediterranean diet, these don't, and we see that it's better. But they have a lot of power in this group of 5,000 people with about 59 people who have developed Crohn's disease. And they had a lot of information about their diet from the questionnaires that people provided. And what they found was that people who ate a Mediterranean-like diet, people that were more predisposed to that sort of food pattern, had a very different gut microbiome, and they had less inflammation in the gut. And this could be important. The diet itself could change the microbiome and reduce inflammation, but the change in the microbiome could also be reducing inflammation. And so again, this is some of the first real evidence that we have that the Mediterranean diet in a large cohort is helpful in people with Crohn's disease for both development of disease and preventing flares. This one actually wasn't published, but one of the things that they put out in a press release I thought was really interesting was that people that had pets in the home and children raised with pets in the home were less likely to develop Crohn's disease. There's something called the hygiene hypothesis, which has been around for many years, since the 70s, I think, so approaching 50 years. And, you know, it's, in our house, we call it let them eat dirt. And it's about how we raise our children. And exposure to natural sources of bacteria, pets in the home, living on a farm, not being overly hygienic and bleaching everything, allows you to educate your immune system and reduces your risk of developing lots of autoimmune diseases. The prototype was definitely allergy and asthma, where this hypothesis was originally applied, but it seems that it's appropriate and holds true for inflammatory bowel diseases as well. So that was everything that I wanted to say about the GEM project. I'm happy to talk about it. It's actually featured in the Crohn's and Colitis 2022 annual report that you got in your packages, and it's on page 19, and Ken Croiteru, as the lead, is talking about some of the work that they've done on that project, which has just been a force majeure in Crohn's and Colitis research. And so I'm going to talk now about our own research program. And I've picked a story, and again, this is the one that Harry Brummer and I started after we met at one of the Crohn's and Colitis events. And basically, we're calling it glycocaging, or using glycocage technology to improve treatments for inflammatory bowel disease. So first and foremost, what is inflammatory bowel disease? Unfortunately, most of the people in this room are probably very well aware of what inflammatory bowel disease is. Two major presentations of disease: Crohn's disease, which is cartooned on the left, and ulcerative colitis, which is cartooned on the right. Crohn's disease can happen anywhere, we say, from gums to bum. So it can happen anywhere along the GI tract. Whereas ulcerative colitis tends to start at the rectum and stretch up to create left-sided colitis. That's what's cartooned here, where the red denotes inflammation along the left-hand side of the colon. And then it can stretch up and be continuous, and even can become pancolitis, where the whole colon is involved. But the disease tends to be continuous, not patchy, like Crohn's disease. Another key difference between the diseases is that in Crohn's disease, people live a little bit more with chronic pain, and ulcerative colitis is superficial. It's sort of the epithelial lining of the colon, and so there tends to be a lot more bleeding associated with those diseases. Any individual can be different, and your symptoms are very specific to the individual and the different causes that happen, genetics, environment in your own life. So that's not true for everyone. Some people will also, and more commonly diagnosed nowadays, is indeterminate colitis, where the inflammation is in the colon, but we don't really know if it's Crohn's disease-like inflammation or ulcerative colitis. So sometimes you get diagnosed with indeterminate colitis, and that diagnosis will change to be one of these types later. A lot of children present with disease in the colon, and that doesn't mean that's where it's going to stay. For some children, it's going to change and become Crohn's disease elsewhere, but the initial presentation seems to be in the colon in most children. So in Canada, the stats now are as little as 1 in 100, as high as 1 in 120 people living with inflammatory bowel disease. That's astounding. So 1 in 3 people now are diagnosed at less than 17 years of age. And I think the total number in Canada is about 1/3 people. 12 years ago, it was less than 250,000, and now we're up to over 300,000, and we're predicting in another 12 years that it's going to be about 500,000 people living with disease. In BC, we have between 80 and 100 people. We had 112 last year diagnosed every year with inflammatory bowel disease. And special considerations for us, children with IBD face additional problems and very specific challenges because they have to be on medication during their growth and development through puberty. Disease is lifelong. We have no cures. So children or early diagnoses of disease are living with disease for a longer time. And that longer time living with disease means that you have an increased risk of all the complications that can go with disease. So really important to be aware and to be on top of it. Manage your disease as best you can. So this is the IBD treatment pyramid, and this is from the University of Alberta IBD Clinic. Very often we start at the bottom of the pyramid, and actually almost exclusively we do this all the time for children with inflammatory bowel disease, and we use this step-up approach to therapy. And it's because we're a little bit scared to give children sort of the biggest, most intense drugs early on because of growth and development. So we'll start with sulfasalazines, we'll move to steroids. When steroids fail, we'll move people to immunosuppressants, and then finally biological therapy. For people with, say, ulcerative colitis that is unmanaged, a final step can be surgery, and sometimes that can be pretty curative for some individuals. Nutritional supports and probiotics can be used anywhere through the treatment pyramid, so anytime that that's appropriate and something that you should talk about with your caregiver if you want to do that. In adults, the number of different treatments and treatment strategies is as high as there are number of GI docs and patient pairs. It's unique and individualized for everyone. Some doctors will use a top-down approach to therapy in adult patients where they're starting with biological therapies. They hear you have a diagnosis of Crohn's disease, you need to be on an anti-TNF-alpha blocker. That would be Remicade or Humira, and they'll start there for the treatment. So Harry Brummer and I were talking about our projects, and one of the things that we wondered is whether or not if we could target a drug specifically to the site of inflammation in people with IBD, if we could eliminate some of those negative off-target side effects and improve the efficacy of those drugs. And in the medical world, we call this increasing the therapeutic index, increasing the value of the drug versus the deleterious side effects that people sometimes experience. One place that's really quite active in research for this is steroids. Any of you who have been on steroids know it can be a really unpleasant road. It can be really tough to take them. They cause side effects. The dose is limiting for what we can provide people, and eventually we have to go off those treatments. And there's a lot of companies, Bayer, Perrigo, AstraZeneca, who are developing different strategies to encapsulate steroids to try and deliver them to the lower GI tract. So we thought that this was a good place to start with our glycocaging strategy. We could address all of the things about limiting dose, limiting duration of time. We could perhaps eliminate steroid resistance and therapy failure. So that was the area that we started working in to try and improve those treatments and expand them for people with IBD. So this is an overview of what the glycocage technology is. Harry has done some seminal work describing the microbiome and microbiome activities in people. And one thing is that people in their microbiome have enzymes that the bacteria provide. They are not found in the human genome at all, but those bacteria can help us to degrade fibers. And so one of those fibers is xyloglucan. It's a specific kind of sugar. So our idea was then, if we took a drug that we could use to treat IBD and put xyloglucan on that drug, then when people took it orally, it would have to get down to the microbiome for cleavage at the site of inflammation. So most of your microbiome lives in your colon, about 90% of it, but about 10% of it is in sort of cecum, appendix area, and the distal part of the ileum, so right between the ileum and colon junction. And that's the most common site of presentation of Crohn's disease in people, and ulcerative colitis is restricted to the colon. So we think by harnessing this activity of the microbiome, we could actually deliver drugs to the sites that are inflamed. And the idea is that we would give drugs orally. They would get down to the distal GI tract. The microorganisms would cleave them, release free drug, and it could be active at the site of inflammation. So we tried this in a mouse model of inflammation that we've developed in my laboratory that has a lot of features that are really similar to Crohn's disease in people with IBD. On the top, the boxes on the left, the pictures, are actually cross-sections of mouse ilia. And again, the most common site of inflammation in people with Crohn's disease. And what we found was if we gave mice on the far right, the highest dose we used was 3 mg per kg of dexamethasone, a very potent steroid. It actually is not used to treat IBD, but it is the most potent on a per molecule basis. And we don't use it to treat IBD because of the side effects. So what we found was at 3 mg per kilogram or 1 mg per kilogram, we could actually reduce inflammation in the mouse gut. If we got any lower than that, 0.3 mg per kilogram, it wasn't working anymore. So we started using our cage dexamethasone at the lowest effective dose of dexamethasone, so 1 mg per kilogram. And that's the bar on the bottom right. And that ileum actually looks really good. So 1 mg per kg was very effective. And then we started titrating that down. So we reduced it threefold to 0.33 mg per kilogram. And we found that it was partially effective, or pretty effective actually. And then we went another threefold lower in the dose, so 10-fold lower dose than uncaged drug. And we found that it was partially effective. It's kind of cartooned on the right here. That's a graph of IL-1 beta production. That's a key cytokine. That's a key driver of inflammation in our mouse model and in people with inflammatory bowel disease. And dexamethasone, you can see that the 3 doses that we used, by the lowest dose there, it was losing effect. At 10-fold lower doses, the cage dexamethasone, shown on the right, was still reducing inflammation in the mouse gut. So we think that it's really effective at reducing inflammation at about 10-fold lower doses than the uncaged drug. And that makes dexamethasone a potential candidate for use in inflammatory bowel disease, whereas it wasn't before. We wanted to ask whether or not it entered circulation. So basically we took our mouse model, we took mice, and we gave them dexamethasone or caged dexamethasone by oral gavage. So we gave it to them orally, just like you would take a pill. And then we took blood samples from the mice at 30 minutes, 1 hour, 2, 4, 6, and 8 hours after dosing to see how much of it moved from the GI tract into circulation. And the black bars are naked dexamethasone. That's just the naked steroid. And you can see that there's a sharp spike in dexamethasone present in the blood 30 minutes to 1 hour after oral delivery. Okay? But if you look at the cage dexamethasone, that's the red circles, it barely enters circulation at all. Certainly there's a little bit of a peak at 4 hours, and that's consistent with the amount of time it would take to move from the mouth down to the distal GI tract in a mouse. So that suggests that our drug is getting to its location before it's being released, and a little bit of it is entering the bloodstream, but not near as much. For chemists, they look at the area under the curve to show you how much drug is being released. And that's the graph on the right there. And you can see naked dexamethasone, very, very high area under the curve. That's the amount of drug that's actually going into the blood instead of to the gut. Whereas the red bar is the amount of caged dexamethasone that we lose to circulation in the blood. So a dramatic improvement when we cage dexamethasone. We also looked at the lungs because we know that the lungs in ship knockout mice, that's our mouse model, we know that the lungs are also inflamed. So on the left, the picture there is a very healthy lung. So that's a cross-section of the lung, and you can see lots of white air spaces, and that's where oxygen exchange, that's where oxygen exchange happens in the lung. In our mouse model, you see that darker pink one, that second from the left, and that is the inflamed lung. So you've got a lot of immune cells filling in the spaces, not very good oxygen exchange, and that's representative of the inflammation that we see in that model. Now, if we treat the ship mice, the Crohn's disease mice, with dexamethasone, it actually affects the lungs. You're seeing a restoration of healthy lungs. But if you treat them with the caged dexamethasone, you don't. So that means dexamethasone is actually getting into systemic circulation in the mice, leaving the gut, and having impacts on other organ systems, which is not what we want for a targeted delivery. Whereas if we cage the drug, we're not impacting inflammation at other sites. It concentrates the drug at the site where we want it to be. So another line of evidence that our caged drug delivery is working really well. The last thing that we really wanted to look at, because an obvious criticism is, do people with diarrhea, do people that are living maybe with a flare and having diarrhea, do they still have the bugs, the microorganisms required to decage the drug at the site of inflammation? And that is a valid concern. So it's something that we wanted to look at. So we got actually fecal samples, that means stool samples, from healthy control individuals. Those are in purple and they're labeled HC, and people with IBD. And those are the other three bars, black, pink, and teal. And we measured their ability, the ability of the bugs in the stool sample to degrade sort of a proxy drug that we used. So basically we caged a fluorescent molecule, so it wasn't fluorescent anymore. When the microbiome in the stool cleaved the drug, then the drug could fluoresce. Okay, and that's what we looked for. We looked for the fluorescing of that drug, give off light. And what we found was that people with inflammatory bowel disease, the three bars on the right, all had significant decaging activity, just as much as people that didn't have inflammatory bowel disease. We've actually stratified the patients with inflammatory bowel disease according to their fecal calprotectin, and that's a measure of inflammation, and that was what part of the data that we collected with those stool samples. People with less than 20 have no inflammation in the gut. 20 to 200 might have some subclinical or even clinically evident inflammation, and people with more than 200 micrograms per gram of fecal calprotectin probably have active inflammation at that time. And that's one of the diagnostic features of Crohn's disease. We're looking for people with FCPs of more than 200 as a diagnosis for active inflammatory bowel disease. And it didn't matter. So basically all people with IBD have decaging activity in their microbiome and could be treated effectively with these caged drugs. So in conclusion, what we found in this work was that glycocaging a drug can reduce the required dose of drug. That could be really beneficial when we're looking at something like steroids, where we limit the drug dose because of the off-target side effects. So we may be able to cage steroids that we already use to treat IBD and have people on lower doses with less side effects. And it's not going systemic, so that's also reducing the side effects. So 2 bonuses for being able to use those drugs. We've shown that the glycocage drugs do not enter systemic circulation. They were not found in the blood of mice after we gave them to the mice. And they don't have off-target effects outside of the gut. So that was the lung data that I showed you. No impact on tissues outside of the gut. We found that all people have decaging activity, and that's whether they have disease, whether they've been diagnosed with IBD, and no matter what their disease activity was at the time that we took their stool samples. In our next steps, we are going to use, and actually Maggie from my lab, who's sitting here, why don't you wave? This is the person to ask about all the details of the project. She's going to do this in a second model of inflammatory bowel disease in mice. And it really is a gold standard in the field to show something having efficacy in at least 2 mouse models before you start moving into larger animals. We're actually going to cage the steroids that we use in the treatment for IBD. And this is prednisone. We're actually going to cage prednisolone. Prednisone is the drug that we give people, but it actually has to be activated to prednisolone in the liver. So it actually requires systemic you have to deliver it systemically for it to become active to reduce to reduce inflammation. So we're actually going to cage prednisolone, the active drug, and just deliver it straight to the GI tract to see if we can dampen inflammation that way. And the other drug that we're going to use is budesonide. And budesonide is actually the big comparator in the research that we're doing. Budesonide is currently being formulated in what they call MMX forms, multi-matrix systems, where they're wrapping it in something to help get through the stomach acid, and then lots of complex molecules being delivered with it to slow down the body's access to the drug. But it's not specific. It's not targeted to the microbiome like our system is. The other thing that we're going to cage is the new JAK inhibitor, Rinvoq. I think it's licensed for ulcerative colitis in Canada, and it is being used in some situations for Crohn's disease, and I think that licensing just came through. It is associated with some severe side effects, and that means that we're not using it early in people. It's being sort of a last resort for people who have failed their anti-TNF or vedolizumab therapies. But it is an extraordinarily effective drug. And the reason we're not allowed to use it earlier in the treatment profile for people is because of the off-target side effects. If we glycocage that, reduce the dose that's required, eliminate systemic uptake, we could actually make that drug safer and more effective for people so that that very effective drug could be used earlier in the treatment pathway, and hopefully improve the lives of people who are failing other medications by being able to skip forward to the next drug. So basically, the strategies that we've talked about, we're hoping will enable some new treatments, things that we don't use to treat IBD because of off-target side effects, safer treatments, and all the treatments that we have are safe, so that's probably a bit of a misnomer. What I really want to say is things that are easier to tolerate. We might not have all the puffy face associated with steroids and the sort of effects, psychosocial effects associated with steroids if we can reduce the dose and target it just to where we need it. So more tolerable treatments that are more pleasant and less onerous for people to endure. And then hopefully a broader application of effective new therapies, things like the new JAK inhibitor and other JAK inhibitors that are in the pipeline. If we can use those earlier and appropriately for people as other medications are failing, rather than having to wait to show treatment failure. And I just wanted to acknowledge the people that have done this work. As I mentioned, Maggie, this is a picture from a conference that we went to last year that happened to be in Hawaii. It was really fun after the pandemic to have the whole lab be able to go together to the conference. So Maggie is actually front and center in that picture. These are my lab members. The people that are in purple, Maggie, Queston, Prab, Nada, and Chloe, are all here at this table and sitting at our booth today. So please go over and make sure you get a pen from them. I wanted to give a shout out to some of the alum that were from my lab that did this. And I noticed in the annual report, this is Peter Dobranowski, featured on page 17. Peter actually did his master's in my laboratory, and he actually made the first observation that allowed us to start moving forward with this technology. And he's been very involved and very committed to Crohn's and Colitis Canada through the years. And what Peter did was he analyzed the microbiome in our mouse model, and he was the one that found that they have this specific bacteria, which is a Lactobacillus ovatus, which contain the decaging activity. So he actually made that initial observation that enabled us, and that's what Harry saw when he heard us present at a fireside chat and said, hey, you have this bug, we could use these decagers in your mouse model. And he hadn't done any biological modeling in animals to that point, which was a necessary next step for him. So Peter enabled that to happen. Matt Luzentala-Simpson did a master's degree with me as well. And he actually did some of the initial work showing the efficacy studies. He started that work showing the efficacy studies in the SHIP knockout mouse in our model of Crohn's disease. He was the first person to actually test the drugs and compare them to the cage drugs. Lots of partners on this, Harry Brummer and his team, Wade Abbott and his team, and Doug Inglis and his team, both at Agriculture and Agri-Foods Canada in Lethbridge, Alberta. And they're actually interested in using this technology to treat diarrheal diseases in animals, which actually limit food production and food safety for people. Deanna Gibson, who is from the UBC Okanagan and a CCC-funded researcher. I think she's actually co-chair of Crohn's and Colitis Scientific and Medical Advisory Council right now. And Natasha Haskey from her lab, who provided us with the human stool samples, and as well Karen Madsen, a CCC-funded researcher from the University of Alberta. So this work started many years ago, 6 years ago, with an Innovations in IBD grant that Harry applied for and was awarded from Crohn's and Colitis Canada. And we've been working with the Glycobiology Network, National Centres of Excellence in Canada. But Crohn's and Colitis, that organization gives you money only if you partner with another organization. So for every $1, you have to bring in $1 from another source. And Crohn's and Colitis Canada has very generously agreed to let us use our funding as the matching dollars for that project. So again, Crohn's and Colitis Canada enabling this research to happen and bring in funding from other sources because of that commitment. Well, thank you very much. Pleasure to see you all here today, and nice to have such a wonderful crowd.
Well, thank you, Dr. Sly, for the presentation. It was very informative and sharing the incredible work that you and your team are going. So let's give Dr. Sly another round of applause. And I found it interesting, Dr. Sly had talked about the GEM project as well. And as all of us know, there is no known cause for Crohn's or colitis and no known cure. So hopefully that project is a long-term study, and we're going to get good, it looks like we're already getting great data out of it, and hopefully that continues to help inform at least a cause. And then, of course, Dr. Sly also talked about some of the work she's doing with the glycocaging technology. And it's, research like that might end up bringing, better treatments to patients more widely. So we're very hopeful with that type of research. So thank you, Dr. Sly, for all your work. Thank you for being part of this first session of the day. Thank you, everyone.